Good evening, everyone. Welcome to this KDSG, KAP, Kenya Urological Association webinar. My name is Dr. Beatrice Omari. I'm your host plus moderator. With me, we have the KDSG repertoire. Her name is ZP. We also have Dr. Oliver Konga, who is our KDSG Education Committee Chair, and also Dr. Shirley, Veronicah. Dr. Shirley is a urologist, and it gives me immense pleasure to have her with us. She is a member of the Kenya Urology Association, one of the new members who has currently joined, and she took the pleasure of having to take us through this topic about sexual dysfunction in type 2 diabetes. I don't know whether we will still allow a few more participants to join before we can start, or whether we can start right away.
I think we have good quorum. We can just go ahead and start. Thank you.
I'll go ahead and just start. Thank you, Dr. Mary, for that wonderful introduction. I'm really happy to be here with you this evening. I'm going to take us through sexual dysfunction in diabetes, our focus being on the pathogenesis, the glycemic correlation, and the clinical management of this particular cohort of patients. So to start us off, we'll look at a bit of, first of all, we'll look at the definition of sexual dysfunction, what it is. Generally, in layman terms, it's the inability to attain and or maintain penile erection sufficient for satisfactory sexual performance. This varies, and when we talk about sexual dysfunction as a general term, it's usually in reference to 4 types of disorders. You can have sexual dysfunction that is related to the disorder of desire. This is where patients present with low libido. Or you can have disorders of arousal. This is where what our discussion centers around this evening. This is where erectile dysfunction falls into. And then you can have disorders of ejaculation, where you can have premature ejaculation, delayed ejaculation, or trouble reaching an orgasm. Or disorders of pain, where intercourse is associated with pain, disorders like dyspareunia in women. And all this form the symptomology of sexual dysfunction in general. So in this discussion today, we'll basically focus on erectile dysfunction, but we know that all these things encompass sexual dysfunction. So the prevalence essentially of sexual dysfunction of any degree of erectile dysfunction is reported to be as high as 52% of all men. And this is 3.5 times higher in men with diabetes, with an onset of 10 to 15 years earlier than their peers, with a total global burden of up to 71.5 in some specific cohorts in research that has been done. However, us having this information, we only, there's a lot of unreported cases, especially locally, because of factors that we shall see going forward. So for us to understand essentially how an erection occurs and what fails us in terms of how do we get into sexual dysfunction, it's important to understand the anatomy and the physiology of this. So I'll just take us through the gross anatomy of the penis. So I'll use the pointer. So the penile shaft has 3 cylindrical bodies. That is under the gross anatomy. These 3 cylinders of erectile tissue, we have 2 corporal bodies, that's the corpora cavernosa, that are usually on the dorsal aspect of the penile shaft. They are paired cylindrical bodies on this ventral area. and they're the ones responsible for rigidity during an erection. And they're usually surrounded by a tunica, the tunica albuginea, which is a bilayered fibrous tissue that is responsible for keeping them, is responsible for holding the pressure during an erection. Then on the ventral aspect of the penile shaft, you have the corpus spongiosum, which contains the urethra, and distally is what comes anteriorly to form the glans penis. It remains more compressible to prevent urethral occlusion during an erection, and it's the one that contains the urethra. Then the supporting structures around the penile gland, you have, as you've said, the tunica albuginea, which holds the two corporal bodies. Then on top of that, you have the Bach's fascia, which is the deep fascia of the penis. It encloses all three layers. In this image, I don't know if I have one that shows the Bach's properly, but the Bach's fascia is the one that's responsible. It's the deep fascia of the penis, and it's a supporting structure. And in some of the reconstructive surgeries of the penile shaft, it's used to reinforce the repairs. And then after that, you have the dartos fascia, which is the outer layer. The dartos fascia is superficial. It's continuous with the abdominal wall. And then you also have the suspensory ligaments, which anchor the penis to the pubic symphysis on either side. Then the other factors of importance when you're looking at the anatomy is the vascular anatomy and the neural anatomy of its supply. So looking at the neural anatomy, you know, erections result from a complex interplay of both the autonomic nervous system and the somatic nervous system. And some bit of cortical control where arousal and attraction comes from. So the innervation of the penis includes both parasympathetic input from the pelvic nerve, and we have the sympathetic input from the hypogastric nerve. And the somatic output is usually supplied through the pudendal nerve, which is responsible for penile sensation. So that is as regards to the neural anatomy. Then for the vascular supply, we have our main blood supply coming in from the internal pudendal artery, which comes in as a common penile artery, then divides into 4 branches. These 4 branches are the bulbar artery, which supplies the bulb, the spongiosum, and the urethra. Then you have the urethral arteries. This image I have doesn't show them very well, but you can see the dorsal artery that runs across the dorsal part of the penile shaft, and then gives off the 4 branches, as I said, the bulbar artery. Then you have the urethral artery that supplies the corpus spongiosum. Then you have the cavernosal artery, which is the deep artery, which is what is important for us, especially when you're talking about erection. So the deep artery is one of the branches, and then we have the dorsal artery, which supplies the glands and the skin. So for the venous drainage, you have the drainage is systematic all the way from the emissary veins, which go into the circumflex veins, then deep dorsal vein, and then periprostatic plexus onto the internal pudendal vein. So what is important to know about both the arterial supply and the venous supply is that for an erection to occur, you have to have proper arterial inflow and venous constriction by the subtunical venules compression for us to get a proper erection. So whenever we are thinking about these patients, a patient who presents with ED, the question we should ask ourselves as clinicians in the mind, from which part of this system that contributes to a proper erection, where is the problem? Is it arterial? Is it the blood vessels? Is it the nervous system? Is it organic essentially, or is it psychogenic? Because all these things have a role when it comes to getting an erection. So once we know this, that there's an interplay between all these things, it is important to understand that for our particular cohort of patients that we're talking about today, ED is a predictor of systemic vascular events to come. If a patient develops ED early on in life, without any comorbidities and presents to your office, as a clinician, you should be able to know that this is the canary in the coal mine. It's a red herring to what could be happening in the cardiovascular system and for systemic events. This is because For penile arteries, they're around 1 to 2 millimeters, yet coronary arteries are around 3 to 4 millimeters. So once a patient gets ED that's vasculogenic, you have, it's a predictor that 3 to 5 years from there, you'd be dealing with something else. And it's usually a clinical sign of endothelial dysfunction. And this presence in itself should be a red flag and should make you alert in the management of this patient. So for ED in itself, we usually look at, when you're looking at organic causes of ED, in the urology's navy, it's a pathogenic triad, as you say. It could be neurogenic, it could be vasculogenic, or from endocrine issues in the system that coalesce in the middle to cause sexual dysfunction. So essentially what I'm trying to say is that it's multifactorial, and these things should be investigated, and these are the questions that should be going on through your mind when you're assessing these patients. For neuropathy, you look at autonomic impairment in the parasympathetic response, which is very important. And then vasculopathy, we're looking at endothelial damage, which causes reduced nitric oxide, which is important in aiding in the dilatation of the vessels within the corporal bodies. For endocrinopathy, we have hormonal imbalance, hypogonadism, and we shall see how this relates to our patients. So going directly to endothelial dysfunction, we know that for you to have an erection, there's the whole cascade of how the nervous supply, and then you get anal production, which causes dilatation of the vessels. So when there's endothelial damage, any type of oxidative stress on the vessels, there's decreased bioavailability of the nitric oxide, which causes cellular inflammation and arterial stiffening, which in turn will lead to failure of us being able to have engorgement of the vessels and having good contraction. The other thing is the neurogenic pathway and the signal disruption. We know for our patients, particularly the diabetic patients, this usually affects how the nerves work, and this will in turn affect the erection process. There will be neurogenic blunting from neuropathy or structural damage of the vessels themselves, which reduces the stimulus threshold. So there will be no vascular response properly for proper activation for you to get an erection. So for patients, other than diabetic patients, there are other patients who usually have undergone, let's say, a radical prostatectomy or have traumatic injury. There's usually blunting of this effect, and how they present is different. But essentially for diabetic patients, usually get both psychogenic blunting, and also we get the tactile blunting of stimulation for these particular patients. So when you look at the correlation between glycemic correlation between as an indicator for patients who have erectile dysfunction, this was a study that compared the HbA1c levels of patients against the IEF score. The IEF score is the International Index of Erectile Function, which is an assessment tool. We shall also go through it, that helps us assess this patient. And there was a direct correlation. The higher the HbA1c was, the lower the IEF score was, meaning more patients who had high glycemic index had lower IEF score. We shall look at this so that we understand what it means as clinicians and how to use it in our daily practice to assist our patients. So away from that, also the endocrine link, the third link in the triad, this is the endocrine link, where we look at hypogonadism and diabetes. It's common knowledge, or rather it's been stated, that visceral fat has a strong inverse self-perpetuating relationship with testosterone in men. High visceral fat reduces testosterone, and low testosterone promotes visceral fat accumulation. High correlation between type 2 diabetes and hypogonadism has been elicited, with symptoms like libido, fatigue, and visceral adiposity. This is the central accumulation of fat, which also contributes to the blunting of testosterone, reducing the effect of PDE5 inhibitors in the system. Here, the action to be taken, especially for patients who come to the office for this particular part of the triad, is to routinely screen for bioavailability of testosterone so that you can relate, other than the HbA1c, whether there are other things that can be modulated so that to improve the sexual function of these patients. So just before I go to that, so having known these three parts of the triad, you have the vascular, the neural, and the endocrine. When a patient comes to the office to a clinician for assessment, a diabetic patient or an otherwise patient who just comes with ED, it's important to take the baseline test. These are the, for the baseline test, the things that you're supposed to investigate for this patient is, number one, you have to do proper lipid, you have to do lipid levels, you have to do HbA1c, and you also have to do your hormonal levels. Here, testosterone is the one that we focus on. And for testosterone, it's important to take the morning testosterone to avoid the fluctuations that they do as the day goes by. As we talk about this particular cohort of patients, there's usually a neglected cohort of patients where women are not, the discussion around female sexual dysfunction is not as vibrant as ED in men. The disparity is that only 19% of women with diabetes discuss sexual health. This is compared to 50% of men. And the manifestation of sexual dysfunction in women is usually arousal disorders, lubrication issues, dyspareunia, or anorgasmia. And the mechanism of how this occurs is similar to how it occurs in men, where we have vascular or neural damage, which is similar to what we see in men with ED. And what we need to do as the clinicians is to break this silence and improve on the screening strategies. I know for a clinician, there's the clinician factor and the patient factor. For the patient factor, not many patients would be upfront and say they have a problem in the bedroom, or perhaps the machinery is not working properly. Most patients don't know how to come out with that information or when it is appropriate to do so. And sometimes you'll find for the clinician side, there's time constraints. Maybe you have 15, 20 patients waiting on queue and you have to give them proper care, and you don't have enough time to spend. And this apart some of the barriers that make this harder in terms of getting this kind of patients to come out with their problems and actually discuss them. So the solutions that are there is either to just go upfront and ask, have you noticed any changes in your sexual function, or are matters correct? The same way we ask about wounds or cuts for diabetic patients, I think it's a common practice that we can take up as clinicians to help elevate these issues. For men, there are validated questionnaires. We have the International Index of Erectile Function for Men. It's a 5-question item questionnaire that could be self-administered or could be administered by the clinician. This one usually has 5 questions with a score of 1 to 5, 1 being severe, then 5 being, in terms of the questions, good. So most of the time what you'll find is that a patient will score anything between 5 to 25. Those who score between 22 to 25 are usually in the green. As you go towards lower, you get patients who have now severe ED or moderate ED or no ED. And then there's also the tools for the females, where you have female sexual function index tool that also is a validated tool that can be used by clinicians in the office. So once you have this, you've diagnosed the patient, you've classified or you've graded them where they are in terms of erectile dysfunction, you ask yourself, where do we start? How can we help these patients? So first and foremost, the basics, you have to start with non-pharmacological as the first step. Yeah, you have to, if the patient is a diagnosed diabetic, glycemic control and all those things to try and make sure the glycemic index is within what is acceptable. Then after that, diet as medicine. There's been what is called the Mediterranean intervention. Yeah, here basically what we are seeing is the introduction of Mediterranean diet to help patients with metabolic syndrome. The Mediterranean diet is essentially a hearty, healthy plant-based diet where a patient is advised to eat a lot of vegetables, a lot of fruits, whole grain, healthy fats, fish, poultry, beans, dairy, moderate dairy, and to eliminate red meat and processed food. Here, the mechanism of how this diet works is to be an anti-inflammatory diet for the patient, which in effect improves endothelial function. This study looked at a cohort of 35 men, and 13 out of the 35 men normalized their IEF score, which went above 22 after 2 years on being on this diet. And in the control group, only 2 out of 30 normalized their IEF score, which shows that diet can be of good influence. Then the other thing is modifiable risk factors, where you advise your patients to stop smoking, because we know smoking narrows the vessels and lowers nitric oxide, and with less NO, less blood flow, and less blood flow will give us erectile dysfunction. Physical activity advice for people who have embraced sedentary lifestyle to be more active. Exercise is lack of exercise is a significant predictor of ED. So encourage the patients to be more active, to lead a more vibrant life where they include exercise in their normal routine. And the other important thing is weight loss. Weight loss can reverse ED in obese men by preserving endothelial elasticity. And also what we had said earlier, the correlation between adiposity and testosterone levels. So weight loss cuts across vascular and also endocrine factors that affect erectile function. So these are part of the modifiable risk factors that we can address when it comes to our patients. When we come into the pharmacological therapy, the first line therapy for erectile dysfunction is PDE5 inhibitors. These ones are responsible for prolonging an erection. So if a patient is arousable and can get an erection but is flaccid, it's not enough to allow for penetration. And depending on the score and where they are on the IEF score, PDE5 inhibitors can be employed or can be a solution for them. So for this ones, we have different groups. You have sildenafil, tadalafil, or vardenafil. Currently in the market, we have tadalafil a lot in circulation, also sildenafil, although all of them are available. But the caveat here for this particular cohort of patients that we're talking about today is that there's a higher failure rate. And this is because these drugs require an intact nitric oxide pathway. Remember, these patients have neurogenic issues that could blunt the NO pathway. So severe neuropathy or endothelial damage depletes NO, blunting the efficacy. And sometimes you might find these patients, you put them on PDE5 inhibitors, and the effect is not felt for long. They might feel it initially. They tell you, I've used it for a few encounters, but now it doesn't work. It's important to have it at the back of your mind that there are higher failure rates with this first-line therapy for ED, and optimization for these patients would be to correct the HbA1c and testosterone levels before declaring that drug failure. As we had said, we have to look at the HbA1c and testosterone levels habitually as we are observing these patients and managing these patients, so that if you also have issues of hypogonadism, you're able to correct that in time to give them a chance before we go into second-line therapy. So for second line and third line interventions, I'll start with the second line, which is intracavernosal injections, which offer direct delivery of vasoactive agents into the tissues, like alprostadil, which bypasses the NO requirement. For alprostadil, this is a synthetic prostaglandin. It's an prostaglandin E1 analog. It binds directly as an agonist to the prostaglandin receptors, thereby activating the adenylate cyclase directly. And what it does is that it bypasses the NO need. So what we'd have done with the PDE5 inhibitors, which are systemic, this one works locally. So for alprostadil, it comes in 10 microgram vials. Usually it's administered in the office. What we normally do It's an intracavernosal injection that the first time you have to do it with the patient for purposes of demonstration, making sure they do it correctly and in a hygienic manner. It's usually done with a small insulin syringe. And based on the response you get in the office with that first dosage of 2.5 micrograms, you'll know whether to up the dose to. So what is usually done, the initial injection should be able to elicit a partial response. So if you're able to elicit a partial response in that particular setting, you can up the dose from 2.5 to 5 micrograms. If the initial dose that you've administered in the office is not able to elicit any response, you do a follow-up injection of 5 to 7.5 milligrams. However, of note is that these injections can only be given 24 hours apart, with a maximum dose of 60 micrograms. If you go above that, you run the risk of getting other issues like priapism. So what usually happens, the patient gets the injection, which is done at around the 3 o'clock or the 9 o'clock to avoid the major vessels that run on the dorsal aspect of the penile shaft. And they usually are able to get an erection, a rigid erection enough for vaginal penetration, for around 60 to 90 minutes. And the advice to the patient usually is that if they have an erection that runs more than 90 minutes, they should inform the primary caregiver, in terms of, in this case, a urologist or whoever was administering the alprostadil. And other than alprostadil, we have other combinations, because some patients you find they get, you've upped the dose so much that they're not getting satisfactory erections. So there are other combinations in the market. You have Trimix. Trimix is a combination of alprostadil, paparazine, and pentolamine, usually administered in the same manner, intracavernosal, for this particular local acting effect. And there are different combinations. You can have the single alprostadil, you can have a bimix, a trimix plus. There are different combinations in the market, but it's important to know that these intracavernosal injections can cause fibrosis, can cause priapism, can cause a lot of pain for the patient if not done correctly, and it can also be delivered systemically, which comes with its own problems. So another thing about its administration, it can only be administered up to 3 times max a week. So that comes with its own like downside. If someone wants to have more sex, then that becomes an issue. So other than the intracavernosal injections, you can have intraurethral pessary insertions, which, as the word just suggests, can be very uncomfortable for the patient. And there are creams also in the market that can be used, but their availability is not as good. So those are the other options as second line. So for third line interventions, we have vacuum erection devices. The purpose of this is mechanical assistance to induce blood flow. What they do, they create a negative vacuum so that you're able to pull the blood from the internal pudendal vessels and all that, so that there's better supply into the penile shaft. Then if that fails, or patients are not comfortable with that because of how mechanical it is, there's the option of penile prosthesis. We have different kinds of penile prosthesis in the market, which is a surgical solution for refractory cases where there's irreversible tissue damage, either from fibrosis or for patients who unfortunately were on intracavernosal injections, who ended up with priapism, with fibrosis. So there are different options in terms of penile prosthesis in the market. So we have you can have the malleable, the non-malleable, the double, the ones that have a pump. Depending on the needs of your patient, all these are available as a part of the third line intervention for this patient. Then looking at the frontier of medicine, because we are always looking ahead, there are regenerative therapies in the market where we have low intensity extracorporeal shockwave therapy. This is where you're trying to create new vessels. We are looking at angiogenesis and tissue regeneration. And here we are trying to restore the natural function and mitigate the symptoms. The studies are still in clinical trials. However, there's promising data coming out of the trials. And there's also the addition of PDE5 inhibitors, low dosing like the 5 milligram to help with the angiogenesis. And also of note, for some patients who present with ED, we put them on a daily dose of PDE5 inhibitors also to try and do the same, create angiogenesis and improve their function during this time. Then now looking at the frontier of this, we can go. So we can look at the clinical management in totality, the algorithm of it. When a patient comes to you, a diabetic patient, a patient you've been doing follow-up on, it's important to ask the question. And I know before, sometimes the patients are not willing to be prompted. The conversation can be awkward at the beginning, but it is important to ask the question because this is a sentinel marker that can predict how the disease progression would go. So use the IEF score the patient correctly, or the FI score for the females. Score the patient, classify them into either moderate, into severe, moderate, or low risk for ED. Then after that, investigate the patient appropriately. Have your HbA1c, have your lipids and your testosterone correctly so that you know where to place the patient, and also as a monitoring tool so that when you employ all these other lifestyle modifications, you're able to monitor whether your patient is also improving. Once we have all this, we need to optimize the patient. Aggressive glycemic control and lifestyle changes, diet, smoke-free, exercise, addition to their routine goes a long way to optimize this patient. And then after that, we treat the patient. As you have said, PDE5 inhibitors are our first line, but in our particular cohort of patients we are discussing today, it could be the failure rate is high, but once we've optimized, they can be used long term because they're the ones which have less effects as compared to the injections and the prosthetics. This is still a similar algorithm. We are supposed to address the sentinel event, target the reversal endothelial dysfunction, try to, when that fails, use intraurethral or intercavernosal therapies, and then surgical prosthetics as the final step in our algorithm. And treatment must be sequential. It must be data-driven. That's why you need all this information from the patient, that you have your HbA1c, you're monitoring from the beginning, comparing it with your IEF score, your testosterone, and all these things you've employed in terms of lifestyle modification, so that you meet standards that, you meet standards that are data-driven for this particular patient. So in conclusion, when we are treating this patient, we are treating the whole patient. Glycemic control is the foundation. And as we've seen, HbA1c has a direct correlation to sexual function. The higher it is, the higher the lower the IEF score, meaning the patients will have worse sexual function. And it's important to remember that all these things are multifactorial. You have to address the sugars, the vessels, the nerves, and the hormones. And treating sexual dysfunction is effectively treating cardiovascular risk for this patient, especially the diabetic patient. And always remember, a good sex life leads to better health, and better health leads to good sex life. These are my references. I would welcome any questions open to discussion. Back to you, Dr. Omari.
Sure. Thank you so much, Dr. Shirley. I think that was a wonderful presentation. You basically highlighted the main, types or causes of organic erectile dysfunction, and tried to, help us understand why it happens in type 2 diabetes, why sometimes the patients tell us that they're not responding to what we consider first line. And I think also just emphasizing the non-pharmacological approach so that patients know that this is a multifactorial issue that can be addressed using all those approaches, even as we put them on pharmacological therapy, and also emphasizing that we look at the patient as a whole. Thanks so much. We really appreciate your taking the time to take us through this topic. So I think when you started off, you mentioned that there could also be a psychogenic aspect, and you spent a lot of time talking about the organic part of erectile dysfunction. Is there anything you could mention about psychogenic? I know there are lots of people who also have many stressors and mental issues, and I don't know what would you talk about that, so that somebody probably, even as they're doing the screening or filling in the forms, they can be able to also factor in that issue and probably know how to proceed.
Thank you for that. When you're called to a panel where you're talking about very organic issues of the tissues, you leave out what is most important. Yeah? So when you're meeting a patient who presents with erectile function, there's two ways of dividing the cause of the erectile dysfunction. Number one is it could be psychogenic or organic. And organic is all what we've discussed. For psychogenic erectile dysfunction is where someone has the inability to achieve or maintain an erection due to a psychological factor. This could be anxiety, stress, depression, or relationship issues, or other physical issues that body physical issues that could make them shy or stress or give them anxiety. And it's a big factor because part of the whole cycle of getting an erection, arousal is a very, very big part of it. So if a patient is not able to have to be aroused, either by sight, smell, or however they get their arousal, it could play a big part in the erectile dysfunction. And especially our patients, when they get some diagnosis, the diagnosis of either disease, either hypertension or diabetes, it could lead to stress. Or whether you have conflict back at home, or now with many chronic illnesses comes expenses where money could be an issue for the family. This also could contribute to the psychogenic erectile dysfunction. And in some quarters, it's been the quote unquote, some people say wife-induced ED, where there's conflict in the household and there's no arousal, and the patient has anxiety or stress or depression that can lead to what is called erectile dysfunction. I think that's what I'd say. It is common. And also, just to add to that, what I'd forgotten is for psychological ED, and what we are seeing as a discussion coming up strongly is what we call pornographic-induced erectile dysfunction, PIED. PIED is also a conversation that could be had for some of these patients because addiction or dependency on pornography has also been shown to cause a lot of psychogenic erectile dysfunction. So as we analyze and we look at these patients, other than the organic factors that I have delved into, the psychogenic aspect is very important. And it is important to also note that we have psychosocial support for such patients where they work with a psychosocial, a sex therapist or psychologists who are trained in sexual health to walk them through it to get them to the other side where whatever is hindering them psychologically from being able to be aroused or getting that cortical aspect to get the arousal running is able to be dealt with.
Thanks so much, especially for emphasizing the psychogenic aspect. If I can summarize briefly, so you said that psychogenic, mostly these are people who are having psychological ED, could be sudden or after a specific event. And like, for example, the ones who have organic or physical ED, this is something that has been persistent, gradual, maybe getting worse over months to years. And also psychogenic tends sometimes to be situational. Maybe the sexual encounter can be good with a different partner, but maybe with their more regular partner that is missing. Or these are people probably who also are good with masturbation, but with their partner, you find that there is no that consistency in terms of having an erection. And typically with psychogenic, maybe you might expect normal libido, but generally with organic AD, the libido is often decreased. And even things probably like morning erections, which would probably preserved or normal in psychogenic, but in people who have organic, we also find such issues patients are reporting that they're reduced or absent. So maybe those are some of the other things that people can also try to screen so that even as they're evaluating patients. And also one more thing, like younger individuals, patients less than 40, people who are having as you've said, pornographic induced erectile dysfunction. So those are some of the other things that may also fall as part of the differential diagnosis. So we're going to the webinar chat, and these are some of the questions. I think the intracavernosal injections are bringing, a lot of questions are coming up on that. So someone is asking, are the intracavernosal injections done on both corpora or it's just a single one?
So you can do it on just one side, because now this is something you're going to do 3 times a week. Or 3 times a week is like the maximum, being generous here with the patient. You can just do it on the one side. What we normally do is with the patient in the clinic or in the examination room, you try and pull up the penile shaft the same way we do as we're trying to catheterize the patient. And when it's straight and elongated, you inject on the 3 or the 9 on the sides to avoid the major vessels that run either on the dorsal aspect or the ventral aspect. So you can just do the 2.5 microgram. And if you're going to up the dose for whatever reason, you can choose the other side. Because you remember we are looking at the response in that given time when you're doing the injection.
Okay.
So yeah, you can do it on one side.
Okay. And another question is about the uptake of the third line therapies, like devices in our setting. What's the uptake of third line devices? Third line therapies, the uptake of both the injections and the devices in our setting. How is the uptake?
The uptake, I would say, I'll talk about the devices. They're there in the market. It's a bit cost prohibitive for most of the patients. That's what I'd say is the limit that would be curtailing its consumption in the market, but it's available. And for the injectables, patients get jittery about the injection. So from my experience, I'd say 50-50. There are those ones who'd come because the problem is really bad. They'd opt for the injectables. But I would say for the prosthetics, the uptake is not as good because it's a bit cost prohibitive.
Okay. There's a question.
And you find most insurances don't cover for it.
Don't cover for these kinds of treatments. So a comment about treatment of female sexual disorder. Anything that is there for treatment of female sexual disorder? Because most literature will talk about use of lubrication, but not specific drugs.
Yes, actually, that's true. Then there's one drug that I saw that in literature that is still in trials for the same. However, there's this what people market as supplements. There's no drug like the one for the male ED, but I know there's one in trials. And for this group of patients, for the female patients, as you've said, we advocate for lubrication. However, it's also important to note the things that we want to reverse in the male patients are also what we want to do the same for the females, to also elevate the symptoms for them.
Okay. Dr. Aswan is asking, can ED or female sexual dysfunction present at any point in diabetics and is not determined by the duration of disease?
Sorry, come again?
So can ED or female sexual dysfunction present at any point in the course of the patient having diabetes, or is it only determined by the duration of the disease? Like the longer the patient has the disease, the more likely they're going to present with erectile dysfunction or female sexual dysfunction.
Not necessarily, because there's some patients who, at the first thing that makes us know that they're diabetic is ED. They come in as patients who are seeking help for sexual dysfunction, one way or the other, and you do your investigations and you realize the HbA1c is off the roof. Like, it can come at any point. However, it's important to note you can have long-standing diabetes with good glycemic control. And you can be a newly diabetic with everything all over the place. So it's not directly, I wouldn't say it's directly correlated, but your glycemic control, the HbA1c, directly is associated with the occurrence of sexual dysfunction. So you can have it at any point of the illness.
Yeah. And then also, again, the fact that a patient who has diabetes can still also be affected by the other issues that cause erectile dysfunction. So it's also important that those are explored from psychogenic, so that we are not also just saying that they could have sexual dysfunction that is only mainly centered around diabetes. What about alcohol and erection or sexual dysfunction? Anything you can say about that one?
Yes. So there's a lot of conversations that have been going on about alcoholism and erectile function and sexual function in general. And I'd put it in two prongs. Number one, we know the whole pathway of an erection to occur starts in the mind. And if there's blunting, like if someone is an alcoholic, there are other issues centrally acting other than just the effects. Yes, it could affect. And the other thing is long-term use of alcohol causes a lot of inflammatory changes in the body, which also could affect the vessels and which could also lead to erectile dysfunction. So yes, alcoholism has a relationship with erectile function, but however, how it affects it, you can look at it as a neuropathy where you have nerve damage, tissues like changes within the brain that affect, and then you can also look at the inflammatory effects of it with vessel impairment, and also endocrinologically, abuse of alcohol for prolonged time affects your liver, which will also lead to some form of hormonal imbalance in the body. So if you look at the whole triad of erectile dysfunction and factors that contribute to it, and also the psychogenic factors, they could also contribute to it. I know in most conversations, people talk about alcohol. There's been the conversation about how alcohol is taking men away from their homes. So yes, there's a correlation to it.
Thank you so much. What about drugs in general? There's a question about role of pregabalin, but I think also it would be, are there particular drugs that, when patients take, the risk of, sexual dysfunction is higher? Or is it, they're, like if I would think about pregabalin, by the time a patient is already taking pregabalin, it means most likely you're treating one form of neuropathy or the other. So, as you're managing that other peripheral neuropathy, the neuropathy could also be affecting their sexual, function, and maybe the pregabalin is the red herring, so to speak.
Yeah, true. I'd agree with what you've said, yes. Because when you're pregabalin, essentially what it means is there's issues with the nerves already. And the neuroendocrine pathway for an erection to occur. So there has to be a neuropathy, because we talked about the centers, the parasympathetic supply and essentially the autonomic supply for an erection to occur. Both the parasympathetic and sympathetic, the centers are within the spinal cord. So if they're affected in any way or the other, either from degeneration, they would affect how the erection occurs.
I think also on the issue of drugs, most of our patients also who have diabetes are most likely going to be on antihypertensive medication, and some of our earlier beta blockers like atenolol would be would be implicated, so to speak, in terms of contributing. May not necessarily be the main contributor, but there's some patients who would say, since I was started on this blood pressure medication, diuretics like the thiazide diuretics, some of them would complain that these medications are sort of reducing their sexual function. Is that something you see a lot in your practice, or this is just documented in literature? But patients, because sometimes maybe they don't come back to us and tell us, or maybe we don't ask enough, and maybe you encounter them during your practice and you find that it is a prevalent issue.
To be honest, I think I have to look at the drug interactions in that sense. But what I know for patients who we see regularly, patients who are being treated for either prostate CA because of how the mechanism or how the drugs work to suppress, because they are androgen deprivation therapy essentially, they work to suppress the system. So those ones essentially come with ED. And also for some patients, because of how when they have BPH, BPE or BPH, how they present, because we've seen the plexus that drains into the periprostatic plexus as the prostate enlarges and then they're put on treatment, they can come in with ED arising from both the effect of the prostate gland itself or the drugs they're on. But for the other systemic drugs, I think I have to look at the interactions and the pharmacological effects of it, especially for the antihypertensives. But I think they could contribute in a manner, but I think I have to confirm that.
Okay. There is also a comment about antipsychotics, especially the SSRIs. We do encounter patients who are on some of these medications and antidepressants, and they do mention about reduced libido, and yeah, and that's something that I do see in clinical practice. So sometimes I send them back to the psychiatrist to work out that the mental illness still requires treatment, but this patient still requires some level of sexual satisfaction. So how does that balance look like, so that no particular area is neglected?
So for some of the SSRIs, I know serotonin, increased serotonin levels reduce testosterone directly, which causes low libido. And that in that way, what usually happens, I think they usually adjust the dose so that once the dose is adjusted by the psychiatrist under supervision, so that you're able to balance the effect so that the patient has a balance between what they need to be treated with and also their sexual function. And in some cases, I've seen situations whereby the SSRIs can be stopped for a while, like a drug holiday of sorts, so that the patient is able to balance between the both. And then also of note is that some of these centrally acting drugs can also cause extreme of either. They can cause erectile dysfunction, or in some cases, we've seen some drugs that cause priapism, that you have prolonged erection, unwanted erections in some of these patients. But for SSRI, mostly the dysfunction is in arousal. So when you're able to stop the drug, they're able to continue with their sexual life. So for arousal, as we said, is one of the dysfunctions. So that is where it majorly affects.
There's a question about how long does it take for the patient to experience partial response? I think this has something to do with the intracavernosal injections.
So for the partial response, you're able to see it during that same sitting of examination. It usually takes 5 to 10 minutes after the injection. You're able to see whether there's response.
Okay.
It's usually in the same sitting. That's why even if the patient goes home, they're able to use the intracavernosal injection before sexual encounter.
So it should be something that they should be able to see that this is almost immediate.
Yes.
That would be an appropriate, okay. I think we have tried to answer most of the questions that have come across. The topic has been quite exciting, and I think our audience, I hope, has gained some insights into how to approach a patient who has sexual dysfunction. Anything you can comment about, any imaging, or the tests are purely hormonal, check for endocrinopathies, is this psychogenic, and because or is there any test, for example, maybe imaging, that can help us to know whether if this is purely arterial, it's a blood supply issue, and our oral medications are not likely going to help. I don't know, what is your take? Or when we think that, or when we try the PDE drugs, or the tadalafil, sildenafil, and they're not working, we send them your way. Then you will continue from there as we manage the sugar and the rest.
Okay. For ED, by the time you're taking your history or doing your examination and you've done your labs, you can be able to predict essentially where the issue is. However, that being said, the gold standard in terms of imaging is a penile Doppler ultrasound, where you can see whether there's any occlusion or how the flows are between the flows are in the penile shaft. So you can do a Doppler. There's room for MRI, but I usually feel like by the time we are getting there, we really we're not sure where we are going. However, there is role for imaging. I can't really say it's not there, but there is a role for it. I've seen a few ultrasounds done, Doppler ultrasounds done for the penile for patients who present with ED. But I feel like by the time we are getting to imaging, we are looking for another underlying cause that probably we've not been able to elicit. But yes, there is role for Doppler, and there's other imaging modalities that you can look at. Especially we are looking for trauma, and do MRIs. Yes, there is room for imaging.
Okay, I think it has been very informative, Shirley. Thank you so much for spending your time and giving us, opening up the topic so that we can look at sexual dysfunction in a more exhaustive kind of way. Thank you for even emphasizing the issues that, it's multifactorial. We shouldn't just have a one-prong approach, reminding us that it also has cardiovascular risk. It carries some cardiovascular risk, especially in our patients with diabetes. How and why we use the medications that are available, that injections can actually be available, although carrying the risks that they do. I know there are patients sometimes who come in so desperate, and they've tried their first-line therapies, they're not working, and I think it would be good for us to refer them appropriately if there are other options that can be of benefit. Just even the fact that we've discussed about psychogenic issues, the fact that sex therapists are available for those who have psychogenic issues so that they can also be addressed. And we are hoping that after this, our practice, especially trying to ensure that, our patients, or screening our patients for sexual dysfunction, will not be a very daunting task, because we seem to have an idea. Thanks again. It's really appreciated. I want to thank everybody who has participated in this webinar. Also our KDSG KP rapporteur, Zippy, for sending all the reminders and ensuring that everybody got a link. She also wanted to remind us that we will get our CPD points after a few days. I hope you managed to register so that that information is available. Thank you, Dr. Olive, who is our chair, for sitting in through this session and reminding us and organizing us even as we are doing this KDSG webinars. And once again, thank you again, Dr. Shirley. So Dr. Shirley, as I mentioned, is a urologist. She is very keen on research, and she's very keen on improving clinical outcomes in urology. And we are hoping that we shall be interacting more in the clinical space. The next time we have another webinar, it will also be in urology. We'll be talking about lower urinary tract symptoms, and we'll see how best we can evaluate for that, whether in our patients with or without diabetes, and how best we can manage those symptoms. I think we can officially close this session, and I want to wish you all a good evening. Sorry, as we are leaving, there's a screen that has been shared about the Kenya Diabetes Study Group, 11th Annual Scientific Conference. So this will be discussing around the evolving face of diabetes and metabolic health in Kenya, from prevention to precision. So it'll happen at Lake Naivasha Resort from the 17th to the 20th of June. There is a poster there, which we shall circulate on all our various forums. We hope to see you there. Once again, good evening.